It's a powerful story, and today we'll be talking a little bit about suicide. I'm going to focus on suicide by firearms, so thanks everybody for coming. I have no disclosures. Very quickly, I'm going to review the epidemiology of firearm suicide. I'm going to illustrate the importance of lethal means risk in suicide risk, lethal means access and suicide risk, and I'm going to talk about extreme risk protection orders. And I'm going to go pretty fast because I only have a half hour, but these slides are posted online, so I'm not going to read everything. I want you to have the access to the data later if you want it. Audience of psychiatrists doesn't need to be told that suicide is one of the leading causes of death in the U.S. Among Americans under 40, it's the second leading cause of death. There's about 50,000 suicides each year in the U.S. For context, that's more than twice as many homicides we have in the U.S. The suicide rates in the U.S. have been climbing. Now, previously, the sort of second half of the 20th century, suicide rates were relatively high after World War II until 1987, which is also the year that Prozac was released in the U.S. Suicide rates went down pretty dramatically to a nadir in 2000, but since then they've been climbing relatively steadily year after year, with the exception of sort of our COVID year, which I gave grand rounds on, I guess, the year before last on why that might have happened. But since that grand rounds, since the year 2020, we've seen an increase in suicides in 2021, 2022. In fact, this past year of data was the single largest increase in 1 year we've seen in suicides in the U.S., such that we now have the highest rate we've had since World War II. Suicide's, of course, a behavior. It's an act that emerges from a variety of factors. I'm not going to list all of the risk factors for suicide for this audience, but I will say I like to think about them categorized into chronic risk factors and acute risk factors, and maybe even more importantly for clinicians who intervene, into fixed risk factors that we can't do anything about and modifiable risk factors. So fixed risk factors, things like being male. Men make up 80% of all suicide deaths. Being of white or indigenous race increases risk of suicide 3 or 4 times compared to other race ethnicities. A family history of suicide, obviously, we can't change. Terminal illness, by definition, is a risk factor for suicide that we can't do anything about. But there are factors we can address: social isolation, poverty, access to lethal means, we'll talk about today, and of course, psychiatric illness. We all know that psychiatric illness is a major risk factor for suicide. Something like 90% of people who die by suicide were found to have a psychiatric illness as a precipitating or predisposing factor for their suicide, and of course, we can do something about that. So we do most of the week. But despite the suicide death rate being so high, it's important to recognize how many suicide attempts there are. The suicide attempt rate is much, much higher. I'm not going to go into this table. You can look at it yourself. But basically, when you look at the last year of data in the U.S., there were about 2 million or 2.5 million suicide attempts in the U.S., about 1.7 million attempts that resulted in no intervention needed, about 500,000 attempts that resulted in hospitalization, which might be a proxy for the severity of the attempt. And yet with all these attempts, there's only about 50,000 suicide deaths. Still a lot, but much smaller than the number of suicide attempts. So why is that? Well, I think to understand why there are so many attempts that are survived, it's helpful to look at the method used in suicide. This table here is from a study by Connor et al., Matt Miller's group up in Boston in 2019. They looked at years' worth of CDC data of suicide attempts. They looked at 4 million suicide attempts in the U.S., almost. And they looked to see the method used and the fatality rate of each method. So you see here, of these 3.8 million suicide attempts in the U.S., only about 300,000 resulted in death. So suicide attempt had a case fatality rate of 8%. But if you stratify by method, you start to see one of the issues. Poisoning, overdose attempt, is by far the most common method of attempt in the U.S. More than half of these attempts were by overdose, by poisoning. But these only resulted in about 40,000 deaths. Overdose, fortunately, has a very low fatality rate. Only about 2% of people that attempt suicide by overdose do die. Contrast that to firearms. For firearms, we see that there were only about 175,000 attempts. Firearms make up about 5 or 6% of suicide attempts in this country, but they result in many deaths with a case fatality rate of 90%. So if you use a firearm, the likelihood of death is very high. Now, this might explain something that every medical student learns. Women have such a high suicide attempt rate, but men have much higher suicide death rate. Simply, this might come down to the fact that men tend to have access to and so use firearms in their suicide attempts. So as I said, about 5 or 6% of attempts are by gun, but they make up the majority of suicide deaths in this country. 55% of suicide deaths are by firearm, by far the most common method. Second is suffocation, hanging, which makes up about a quarter of suicide deaths in this country. In fact, when we talk about gun violence, we often talk about mass shootings. Of course, they're tragic, and homicides, but the majority of gun deaths in the U.S. are by suicide. Now, I mentioned there's many risk factors for suicide. We could spend a whole hour talking about the genetic factors, personality factors, distress. All of these risk factors for suicide ultimately follow a pathway that results in a suicide attempt being made here. And when that suicide attempt is made, it either results in a death or in a survived attempt, a self-harm attempt. And really the only thing that distinguishes from here after an attempt is made, whether it results in death, is the method used. If the method's likely to be lethal, it's likely to be death, and if not, it survived. And the choice of method ultimately comes down to what's accessible to that person at the moment when they have that suicidal impulse. To understand that, I like to point out how impulsive suicide can be. But here's sort of an epidemiologic study. Of course, every suicide death is different. I interview families that have lost folks to suicide, and everyone's story is unique with some common themes. But as epidemiologists, I like to look at the large-scale numbers, the proportions. Simon's study in 2001 is a great example of that. Simon looked at about 150 people who had made serious suicide attempts. They were hospitalized, and in the hospital they were interviewed by the study team. And the interview would have been along the lines of, maybe you were depressed for a while, thinking about suicide for a while, maybe. There was that ambivalence that we're all very familiar with. But at some point that ambivalence resolves and the decision is made to end your life. How much time passes between that decision being made and the act? How quick does that happen? He found that 87% of these folks reported that it was the same day. Within 24 hours, 87% of them had gone from decision to action. 71% within an hour, about half of them within 20 minutes. About a quarter of them, like Brian, was less than 5 minutes. It can be very rapid. And so when you have this very rapid impulse to die by suicide, this decision being made and then acting so quickly, you use what you have available. If what's in the bedside table is Tylenol, you'll attempt an overdose by Tylenol, which, as I mentioned, is fortunately survived 98% of the time. But if it's a firearm, the chance of survival is much lower. So he uses a gun for suicide, not surprisingly, people that have guns. These are two maps. The orange map here is shaded for the rate of firearm suicide in that state. So you see lots of firearm suicide in places like Alaska, Montana, Wyoming, Idaho. And on the right here, I don't know if you can see from there, is the proportion of households that own guns in each of those states. So like half of all households in Montana, Wyoming own guns, almost 2/3 in Alaska own guns. And these maps look very similar if you cross your eyes and overlay them. But it's been looked at a little bit more scientifically. Several studies, I won't go into the details. Matt Miller looked at geographic areas of the country with high gun ownership versus low gun ownership and found that in areas with high gun ownership, there's twice the firearm suicide rate. There's 50% higher suicide rate in general, all causes, because of firearms in those areas. Actually, that number is even higher for kids. For kids in high gun areas, they have a 90% higher total suicide rate compared to kids in low gun areas, controlling for all the things you want to control for. I think the reason that it's higher in kids is that kids have less options. So if an adult becomes suicidal, they could get in the car, go to the hardware store, go to a bridge. A kid has what's in the house, and so if a gun's in the house, it's a bigger risk factor there. A study by Danielle Steele-Smith found that for every additional gun shop, more access to guns, every additional gun shop in an urban county, there's a 1% increase in suicides for each shop. That study, actually, the second author of that study is Cynthia Fontanella, who'll be here tomorrow for a research conference if you're interested in coming, just to plug that. Meyer 8. Engelmeyer found that individuals with gun access have triple the rate of suicide compared to those without gun access. Studies have looked at soldiers who keep a loaded gun at home or carry off duty. They have 4 times the risk of suicide compared to other soldiers, high-risk group soldiers, but even higher if there's a gun. Now, when I talk about this data, what I often hear from folks is, well, yeah, sure, guns are definitely lethal, no argument there. But if we take them away, won't someone just find some other method? Won't they just find some other way? And this is a widely held belief. In fact, Matt Miller did a study where he surveyed people, and he asked them, if someone was stopped from jumping off a bridge, off the Golden Gate Bridge, if they pulled them off, would they just find some other way later? And 74% of Americans said, yeah, most or all of them, they just find some other way. It's widely believed. But the reason that Matt chose the Golden Gate Bridge for that study is that the Golden Gate Bridge is particularly well studied. So the Golden Gate Bridge, obviously a popular suicide site in San Francisco. They did a study where they looked at people who were thwarted from that suicide death. And the Golden Gate Bridge, there's about a 1% survival rate from the fall. So Seiden and his group in the 1970s looked at people that had either survived that fall or more commonly have been pulled off the bridge by police or passersby, or he got caught in the scaffolding. They survived what would have been a very lethal attempt. He followed these 515 people for a median of 26 years. So this is a follow-up that I can't get funding for these days. But he followed them for a long time and found that less than 5% of them went on to die by suicide in that very long follow-up period. There's been a lot of studies like this. O'Donnell looked at people that jumped in front of the subway in London. Again, very lethal, but you can fall between the tracks. Followed almost 100 people for a decade and found that less than 10% of them ever went on to reattempt and die by suicide. There's meta-analyses of studies like this, and the bottom line is that 96% of people who survive a serious suicide attempt continue surviving indefinitely. Only about 6% of people go on to die later by suicide. Remember, these are the people we're seeing, right? We see people that come in after an attempt. We see people that are chronically suicidal. Fortunately, most of them, not all, will continue to survive. So then what happens if we have a popular lethal method and we take it away? It's been looked at in many naturalistic studies, intervention studies. In the UK, most of you are familiar with the story of how coal gas ovens were used for suicide because they produced carbon monoxide. Sylvia Plath famously died that way. But when coal gas ovens were taken away from the UK for economic reasons, switched over to natural gas, suicide rates by carbon monoxide dropped by 80% with no replacement by other methods. In Sri Lanka and other agricultural economies, you take away pesticides, which is the most common method. When class 1 pesticides were banned in Sri Lanka, suicides there dropped in half, no replacement with other methods. Back in the UK, paracetamol, Tylenol, was used in many suicide attempts, and even though it has a low fatality rate, does result in death 2% of the time. And so Parliament, in order to prevent suicide there in 1998, made it so that if you sell paracetamol or aspirin, over-the-counter headache medicines, you have to limit the sale to 16 tablets at a time. You can't buy a tub of Tylenol like you can here at Costco or something like that. And when they did that, because of less stockpiles of Tylenol, paracetamol in their medicine cabinets, suicide rates by overdose there dropped by 22%. In Israel, soldiers were using guns for suicide almost every time, and so guns were kept on base over weekends, and suicide rates dropped by 40%. And I want to talk about just one last study that's close to home. Those of you who come from DC or who know DC are familiar with the Ellington Bridge there. The Ellington Bridge for a long time was the hot suicide spot in DC, like the Golden Gate in San Francisco. There was a lot of conversation about trying to get bridge barriers put up on the Ellington Bridge to stop people from jumping. And the response from people that sort of didn't want to spend that money said, well, people will just go to the next bridge. There's lots of bridges in DC, lots of high bridges. In fact, this is a map of where the Ellington Bridge is in DC. You see that the Ellington Bridge is right next to the Taft Bridge. They both go over the same Rock Creek Ravine here. You can walk from the Ellington Bridge to the Taft Bridge. It's like 1 block. It's very close. So they said, oh, if you barrier the Ellington Bridge, they'll use the Taft. Well, we did a study, myself and Lanny Berman and Allison Athey, and looked at what happened when they did put those barriers up in '86. We found that there was a 90% reduction in suicides from the Ellington Bridge. Not surprisingly, it became harder to cross those barriers. But there was no increase in suicides in the Taft Bridge, didn't go up, or in any of the other bridges in DC, or in suicide by any other method. Barriers are very effective and they work. And in America, here we're talking mostly about guns as a lethal convenient method. And sure enough, any policy change that's affected the ability to rapidly access guns has resulted in a decrease in suicide. So DC starts requiring gun licensing in the 70s, suicides go down 23%. Dan Webster here at Hopkins looked at child access prevention laws that mean that if you have a kid in the house, you have to keep the gun locked up, and found that just passing those laws reduced teen suicide by 8%. Any law, essentially, that decreases access to guns tends to show a robust effect in reducing suicide without replacement to other methods. And that's what brings me to red flag laws, which is a policy that's relatively new here that reduces gun access that I want to spend most of the time here talking about. Some of you are really familiar with red flag laws. They have different names in different states. They're essentially laws that allow police or family members to petition for someone who might be at risk, if they have a gun, of hurting themselves or others, to have the gun removed temporarily, and also to temporarily put them on the do not buy list so they can't buy another gun temporarily. They go back to Connecticut. Connecticut in 1999 passed the first one of these in response, obviously, to the school shooting there. But then after the Parkland massacre in 2018, there was a wave of states passing laws like this. Maryland was one of the states that passed that law. In Maryland, when we passed ours in 2018, we were the first state to allow physicians, really any clinician, to file an IRPO, not just police or family members, but if a clinician was concerned, we could do it as well. That was Maryland. Now there's 21 states and DC that have red flag laws, and it's a growing number. More are coming online every day. Minnesota and Michigan both came online, Michigan just this month and Minnesota next month, both now adding clinicians as filers. That's becoming an important part of the law that we'll talk about. Now, the earlier versions of these laws in Connecticut and Indiana, before the Parkland wave of passing this law, have been well studied. There's enough time for them to have been studied. Now, Jeff Swanson at Duke has done a lot of this work. Swanson looked at Connecticut's version of the law through the lens of public health. So we looked for a number needed to treat, right? Because if we're doing any intervention has a risk and a benefit. With this intervention, you're taking away someone's Second Amendment right. You're doing it temporarily, but nonetheless, that's a problem, and you want to make sure you're doing it for good reason. So Jeff looked and found that for every 10 or 11 guns seized, for every 10.6 guns seized in Connecticut's law, 1 life was saved. That's the number needed to treat. So it's up to each individual person to decide if that's a good enough justification for removing that right temporarily, but I think it's a pretty solid number. It's been studied in Indiana. Cavisto and Fallon looked at Indiana's version of the law and found that it reduced firearm suicides by 7.5% consistently over 10 years, and there was no replacement to other methods. I mentioned clinician filing, and that's something that I'm looking a lot at. We actually have a paper under review at Annals right now that finds that for states that do have clinician filing, remember that's Maryland, and actually more recently Connecticut has come online with clinician filing, New York, Michigan, Minnesota. States that have clinician filing have a further 15% decrease in firearm suicides compared to states that have ERPOs without clinician filing. And that decrease is actually, if you stratify by race, largest among black populations. So black communities see a 24% decrease in firearm suicides with those laws. I hypothesize that maybe it has to do with the fact that in black communities or in any community that has a rockier relationship with the police, people might not be as willing to go to the police to file them, but might go to their doctor for that. Still, most clinicians are not using this law, and we'll talk about that in a second. Since we're here as Maryland psychiatrists, I want to tell you a little bit about our version of the law so you know how to use it. We were, as I said, the first state to allow clinicians. The law in Maryland can be filed by family members, roommates, romantic partners, police, or clinicians. Clinicians include physicians of any kind, nurses who work in mental health, social workers who work in mental health, or state health officers. You can file an EP simultaneously, because this is an overlapping population, of course. Filing does require the petitioner, that might be you, to go to hearing, and that's a challenge. The respondent is the patient in our language, must pose an immediate and present danger to self or others by being armed. The order results in police removing any guns from the house. They'll go to the house and they'll take away any guns that are there. And they'll also put them on the do not buy list. We can get into details of it later if you're interested. I will say that these can be filed against parents of or guardians of a child in crisis. So if you have a pediatric patient who's at risk, but they're not the gun owner, but there's a gun in the house owned by a guardian, and the guardian is not willing to take the gun out of the house during a crisis period or store it safely, in extreme situations, you can file this thing for the gun to be removed from the guardian in that situation. Illegal guns, which are common in Baltimore, are not returned, but there's no charges pressed for having a illegal gun. In fact, when you file one of these, you're not putting your patient at risk for any legal ramifications aside from gun removal. If the police find heroin on the table, they won't be prosecuted for that. This is a very narrow warrant to get the guns. You don't want to be sending your patients to jail. That's also not good for their mental health either. Now, this does avoid problems with having families take the guns, right? So we have always the option, in fact, I used to use before the ERPO law, the option of saying to a patient who you're worried about, hey, can you give your gun to your brother-in-law across town? You know, can he hold it for a while? You're in a crisis. It's a legal gray area because Maryland's a background check state, so you can't just kind of give someone a gun. They have to go through the whole permitting procedure. And it also puts the brother-in-law across town in a weird position. Like, when do they give the gun back? How do they decide when they're safe to give it back? Or what if that gun is then stolen or used in a crime, that kind of thing. So it's a little bit cleaner. Anyway, Maryland has been really successful with the ERPO law. We have been a champion of filing ERPOs compared to other states. I should say that the state with the most ERPOs filed per year is Florida, which is surprising to some folks. But it's been really active in Maryland, too. We actually have the highest rate of ERPOs filed. Florida is bigger than us. In the first 2 years or so of our ERPO law, we filed almost 2,000 ERPO orders. Compare that to California, which is another blue state, where in their first 2 years, even as a larger state, they filed less than 200. Mostly we're filing them in rural areas, semi-rural areas. Baltimore City has not been filing that many ERPOs. And despite the fact that we're using them so often, still less than 1% of ERPOs filed in Maryland are filed by clinicians, despite our unique ability of clinicians to file. We've been wondering about why that happens. Why are physicians not filing them here? So we did a small survey. This is with Shannon Frattaroli, and Holly Wilcox is here today, and some folks from the ED and the pediatric service. We surveyed 92 physicians at Hopkins in psych, peds, and in the ED, people that are most likely to see patients that these would be relevant for. We found that only one of them had ever used an ERPO. It was a psychiatrist, for what it's worth. There was generally low knowledge of ERPO. Most people, over 70% of physicians surveyed, had never heard of the law at the time. But when we explained the law to them in the survey, we found that most of them said that they saw patients who would be, potentially good participants for this sort of an order at least a few times a year. And then we asked them, okay, so when you see those patients, are you willing to file an ERPO now that you know about it? And more than half of them expressed a willingness to use the ERPO on those patients. Not all of them. Remember, they just defined it as patients that should get an ERPO. They said, well, would you do it? About half of them said yes, half of them said no. So we wondered why that might be. We asked about the barriers, and unsurprisingly, time was a big barrier. There's some paperwork. It's not a lot of paperwork. It's about a page form, similar to an EP. But you do have to go to court, as I mentioned. Now, we can't leave the inpatient unit or the ED to spend the day in court, unfortunately. So that's a huge barrier in why they're not being filed. There's also issues with therapeutic alliance, although those ones aren't so far into us as physicians that have to file EPs sometimes. 87% of people said that if there was some kind of coordinator, some kind of navigator that could help them do the paperwork, go to court for them, yeah, then they do it, if there was a navigator. And this is a system that exists for child abuse, for instance, in our hospital. In the pediatric service, if you're an inpatient peds doc, you can call for a navigator to help with child abuse cases. If someone has like a spiral fracture or something that looks like it could be child abuse, you get someone else involved, and they're the ones that file the paperwork. They follow up in court if there has to be legal proceedings. So we were thinking that might be helpful for gun navigation too, for ERPO navigation. And so we were actually able to get about $500,000 from Brendan Scott from the mayor's office to start a service like that. So we're now currently piloting a service where anyone at Hopkins, whether you're in the ED or on an inpatient unit or an outpatient doctor, if you're worried about someone, you can call BCRI. Most of you know BCRI, Baltimore Crisis Response. You can call them through their hotline. Also, many of you might know this already. If you call 988 in Baltimore, it just goes to BCRI. So you can call that number, and they can send somebody to evaluate your patient on the unit, in the ED, at their place of living or their place of business. They'll evaluate them. BCRI is a mobile crisis team. They'll talk to them about gun ownership. They'll do some lethal means counseling. Maybe they'll offer gun locks or safe storage boxes, or in extreme situations, they can file these ERPOs. Then they're the ones to go to court. And that service is available. Now, we've actually done it a couple times on MIRE 3 and 5 so far. We're just getting started. All of you are eligible to do it. So if you have a patient this is relevant for. There's some safe storage options I just want to mention. There are many things you can do to reduce access to guns, ranging from gun locks to safes, that kind of thing. There's also out-of-home storage. You know, for someone in crisis, you might want to suggest that the gun is temporarily taken out of the home. It can be stored with family members, as I mentioned. It's a gray area. You can store guns with law enforcement or with gun stores. Maryland has a safe storage map. This is actually created here at Hopkins. The safe storage map URL is here. You can go online. It's a Google map that shows gun stores, shooting ranges, other places that have agreed that they'll store your gun for you in a crisis, no questions asked. It's not ideal because then how do they know when to give the gun back, and there's legal issues, that kind of thing. But it might be less paternalistic than an ERPO, right? So it depends on the level of risk. In order to pursue any of these interventions, whether it's offering a gun lock or filing an ERPO, we need to know if the patients have access to a gun. To do lethal means counseling, we need to do lethal means assessment, right? We need to know if there's a gun. And frankly, it's just not always happening. It's unclear how often people are asking. I noticed that the residents that I'm working with ask every single time, but I suspect it might be because they're working with me and they know this is my area. So I don't know how often it's happening. We did a study in the pediatric ER. I actually did 3 different studies with Aubrey Davini looking at the pediatric ER here to find out when patients come in with a psychiatric complaint, are they asked about gun access? We did one of the studies was a survey of clinicians. We asked all of the clinicians, all of the clinicians working in the pediatric ER that ever interface with people with a psychiatric complaint, whether they are trained in lethal means assessment. Only about half of the clinicians said that they were trained. About a third of them said that they were trained in lethal means counseling, what to do once you do identify the gun. In fact, when we gave a hypothetical situation where there was a patient at risk with access to a gun, only 42% of the clinicians said that they would often or almost always counsel the families to lock the gun up. Remember, these are kids in the pediatric psych ED. And the reason that they said that they would do it only 42% of the time is that they saw it as someone else's job, right? It was 84% of them said this is a social worker's job. And it might be. Maybe that is the role of the social worker. That's why we use social workers in our Navigator project. We also did sort of a slightly more objective study than a survey. We looked at the records in EPIC of 1 year's worth of visits to the pediatric ER for psychiatric complaints. So this is with Zoe Lucier, who you might remember graduated from a residency last year. Zoe looked at 1 year of patients, which is 625 patients that visited the pediatric psych ER, went through EPIC, and found that of those patients, only 11% of them were screened for firearm access, or at least documented to have been screened for firearm access. And of those 11% that were screened, so only 11% of pediatric psychiatric admissions are screened, of those 19% of them did have a gun, right? So we're missing a lot of guns potentially. All the people were not asking. And we were hoping that maybe it was a bias in who was asked, like maybe the people at highest risk are the ones asked, and so that would make a lot of sense. But we did go back and look, and we tried to see if there was a correlation between the Columbia Suicide Risk Assessment or the ASQ. All the assessments we did on there, no correlation. There wasn't a higher proportion of people being asked if they were higher risk. There was a racial difference. People tend to be asked more if they were white, but no other thing really stood out. Now, this last slide, I want to talk about psychological autopsy. I'm just going to give sort of a preview of the psychological autopsy studies because I want to spend all of my next grand rounds just talking about these studies. But I do want to say that one of the reasons it's such a problem that we're not asking and talking to patients about gun access is that families want to be asked. They want to know more about this. Usually, I learn about this after the fact. So I perform these psychological autopsy studies. It's where I review families who have lost people to suicide. This sub-study of psychoautopsy is specifically looking at suicides among young people who used a firearm. So so far we've gone through 12 families. We've interviewed 12 decedents' families, and we have some preliminary data. I will say that these are, in general, when we talk to these families, these are kids who do have some signs of risk. But most of these families, 75% of them had kids that were in mental health treatment. About 2/3 of them had been reporting suicidal ideation. 75% of them had reported a suicide plan at some point. And 33% of them, 1/3 of them, had had a history of suicide attempt themselves. So people with some flags of warning. 3/4 of them used a family firearm in their suicide. We asked the families if you had known about the IRPO law, if it had existed when your child died, or if you'd known about it, would you have filed it? So this depends on a couple things. They have to have known the kids at risk, and they have to be willing to do this. We found that 83% of these families, in hindsight, of course, report yes, they would have filed this if they'd known about this law. Reasons that people might say that they wouldn't file it would be that there's no indication of risk. There was no way to know. Or we had one mother who said that the child would have found another way to die by suicide. There wouldn't have been a reason to file that. And of course, that's something that lethal means counseling might have helped to dispel that notion. Here's just a quote from one of the mothers. If someone would have just suggested, you might want to take the guns out of the house, that's what I would have done, of course. But we didn't think. So this is something that people aren't being educated on as much as they could be. All right. So I don't have time for questions, so I'll just end here. I'll say suicide is the leading cause of death. The rates are rising. It's preventable. It can be an impulsive act, as you heard about today, and as you see in the majority of cases. People use what they have available to them, and if what they have available to them is eminently survivable, they survive and keep on surviving. But if what they have to use is very lethal, the chance of death is very high. In other countries, that's been coal ovens or pesticides or paracetamol. But in the US, it's guns, which is a politically fraught topic, but one that we need to address. Patients and families are not being made aware of suicide risks posed by firearms or the tools available to them. If we screen for firearm access, if we regulate access to firearms, advise safe storage, and generally decrease firearm prevalence, we'll likely save lives. And in extreme situations, of course, IRPOs can be used, especially here at Hopkins, where we have a brand new service. So, thanks to all of my collaborators, and there's some time for questions.
Thank you, Paul. Great presentation and great work. Let me start with this major action item, which is you've got a new team. I don't know if you just want to say a little bit more about how folks can access your navigators if they need to.
Sure. So the new team is through BCRI. So you can call BCRI's warm number, the same number you call when you're in the ED and you want them to assess someone down there. You can also call 988, and if you're calling from a Baltimore number, they'll send you to BCRI. And you can say, I'm interested in a firearm navigator, that's what we're calling them, or safe storage navigator sometimes. Sometimes you'll have a BCR operator that doesn't recognize it, I've heard, and you can just say, can I talk to Quinita? Quinita is the one coordinating for us. Or you can call me, and I'll help. We've done it on Meyer 5. The first one we filed was on Meyer 5, and the system was not flawless. We learned a lot from that. We've modified the system since. The last one we did was on Meyer 3. It was a situation that it worked out really well. The navigators came and they were really helpful. They ended up not filing an IRPO, but talking to the patient a lot about gun access. By the way, the reason that they didn't is because the patient was a felon and couldn't buy a gun anyway, and his gun was illegal, and he agreed to sell it to a friend of his, and so they helped with that process instead.
Great. Thanks, Dr. Tobolowsky.
That's a great question. Well, I'm going to repeat it real quick. When you have an involuntary patient, as many of you know, during the hearing when someone's declared to be certifiable, there's an extra form the judge can optionally fill out that says that person also should not be allowed to buy a gun. And how is that different than ERPO? So first of all, everyone should know that that only applies if the person is suicidal. Right? So if someone is at risk for owning a gun because they're homicidal, which is something we worry about a lot in these involuntary cases, the judge is not allowed to forbid them getting a gun. That law is specific to suicidality. That bothers me a lot, but that's the way it's set up. The other thing with that optional extra thing the judge can do is it doesn't require relinquishment of any guns. Any guns they already have, they still have. They're still in the house regardless. They just are put on the list to not be able to buy new guns. And even that, there was a paper that came out from Emmy Betts about a month and a half ago looking at state by state how reliable that process is. Like, does that actually get them in the NICS list? In Maryland and most other places, no. There's not a good mechanism for actually getting that paperwork to the federal government. So people are forbidden from buying a gun, but they can still just go and do it, which, by the way, is a big problem because there's a downside to having that law. You might imagine that patients that are worried about losing their gun might not be honest about psychiatric symptoms for that reason. They don't want to lose their gun, so they might withhold things. So it has all that downside without the benefit of them actually not being able to get a gun. So it's
Right. Interesting. Lots of questions. Dr. Bryant.
That's a great question, Barry. And I'm just going to repeat Dr. Bryant's question. By the way, Barry is one of the interviewers for the study. He's interviewed patients for the psych autopsy study, so I appreciate it, Brian. So the standard of care I'd like to think is changing. I only have anecdotal evidence because I'm called all over the country. I've given talks now in Michigan and Minnesota, places that have these laws coming online, to help them figure out how to do firearms screening and how to actually implement this stuff. So hopefully that means that they're planning on doing it. There have been several studies besides the one we did at Hopkins looking at the prevalence of lethal means screening. Our numbers are not much worse than other places. Even places like Colorado where there's a lot higher gun ownership, people are also not being asked. But if you look at these studies as they come out year by year, the numbers tend to go up higher. We're doing better at it. We're getting better at it. And also that reflects a broader issue, which is that in the U.S. we're starting to recognize the dangers of gun access broadly. This has been going on not just in public health, but the country at large. Legislators are more and more willing to take on these laws. In fact, in Maryland, there was more laws addressing the mental health components of gun access this year than I've ever seen. We can talk about those specific laws if you're interested later.
That's a great thing. Dr. Kalika.
Great question. I feel like I planted these questions. That's a great question. So the question, just to repeat it, was, would we file an ERPO if someone doesn't have a gun? They just might be able to get one. And the answer is yes. So the ERPO law is not intended just to take away guns. The idea is if someone's at risk, if they could access a gun, so if they could buy a gun if they have a gun. So theoretically, it would be a good idea to talk to anyone that's high risk if they get a gun and ERPO in that situation. In practice, that's difficult, right? Like maybe if we had more navigators, we would file them more often. But yeah, in theory, someone that's at risk for having a gun, even if they don't have a gun now, it would be good for them to not be able to buy one. Yeah.
Thanks. Dr. Osman.
So Sammy's question, I'm just going to repeat it, is there a process to streamline so that we can bring these to the hearings and just do them on our Wednesday hearings that we already have with administrative law judges? Unfortunately, no. So the way this law is written, this gets a little bit technical, but the judges we meet with on Wednesdays are called administrative law judges. The ERPO, like a domestic violence protection order, which is modeled on, needs to be in front of a real judge. Now, there's been some talk about whether we could modify the law to allow administrative law judges to do it. Actually, the ERPO law, there's a modification amendment that's up in Maryland this year. Actually, if anyone wants to testify, it's on the 18th. And we were going to try to get that amendment in, but we were told that the political will might not be there. So no. In the future, that would be a good thing to do. If we could just do it with the judges that come to us already. In New York, they can do that. But also, interestingly, in New York, there's a large fee for filing an ERPO, which has been a barrier. Who knows? But yeah, that's something we can't do yet, but I hope to do it one day.
Interesting. Other questions? We got many more. Dr. Franco.
The question from Cleo is, when BCRI is called, they seem to want to prefer to see the patient later in the admission. So say, call us back when they're close to discharge. No, I think that the reason for that is that BCRI is used to coming at the end of admission because they're our outpatient plan. There's not a good reason. And my guess for why they do that is because they might have noticed that when they get called early in the admission, things change. And then they've kind of wasted their time for when they're being referred to a crisis bed. So my guess is it's just related to that habit, and I'm glad you brought that up because I didn't realize they were doing that here. So I'll talk to Quinita and point that out. Because I know that, for instance, like the last Meyer 3 patient, it ended up being something that kind of almost delayed discharge because there was this wait. So yeah, we'll see if we can get them to come in earlier. There's no good reason.
Other folks? Yes. Dr. Wilson.
You're just like reading my bibliography, I guess. So I've done a lot of studies on the type of gun used. In Maryland, long guns are used in 28% of firearm suicides. With kids, it's a higher proportion. Youth in Maryland, especially in rural areas. In fact, if you look at rural firearm suicides in youth, it's 80% long gun. Long gun means shotgun or rifle. This is relevant because laws are different in terms of handgun restrictions and long gun restrictions. In Maryland, until recently, actually the reason I wrote this paper, until recently, you could buy a long gun with no minimum age limit. You have to be 21 for a handgun, but no permit to purchase, no background check, that kind of thing. We've just closed that loophole. But yeah, long guns are just as much of a problem as handguns. I remember a delegate in Annapolis fighting me on that when we tried to close that long gun loophole, saying, what are you talking about, Dr. Nestadt? How's someone going to use a long gun to die by suicide? They can't even reach, and he pantomimed it. That delegate later ran for governor. And obviously that's not true. We know famous suicides like Kurt Cobain or Ernest Hemingway who've used shotguns. And as I said, we later had the data to show that a third of these deaths were by long gun, which is data that I believe helped pass that law, and we have now closed the long gun loophole.
Time for maybe one more, or Dr. Tice.
Yeah, that's a really good point, Jason. I'm just going to repeat that question. Are we running into problems with physicians not wanting to screen on ideological grounds? Remember, guns are obviously a politically hot topic. People have strong opinions on guns. Jason and I have actually written quite a bit on this. Right now, we've just finished a white paper for SAMHSA on the use of ERPOs, and that's come up in the paper. In Maryland, it's not so much of an issue. We're a pretty blue state, so I haven't run into that. But when I've spoken in other places, so I think a lot about Michigan. I went to Michigan when their law was about to come online, and I was speaking there to child psychiatrists. And there was one child psychiatrist from Upper Peninsula, Michigan, which for those of you that don't know Michigan, it's sort of a more rural. And she said, listen, I'm the only child psychiatrist like anywhere nearby. And if I asked one person about guns, it would be all over social media, and I would no longer have any patients, and then these kids would not get care. So I got to admit, I'm not going to do it, she said to me. And it's a hard thing to navigate. I mean, what I advised, so this is anecdotal, of course, what I advised her was, to get around the political issue is to try to make it as public health oriented as possible. So I talk to parents who have kids at risk, and I'll say, think about it as a developmental issue. At this stage, kids look around, they explore things, they get into liquor cabinets. So this, not making it political. The same way as we might ask about or remind people to wear a helmet on a bicycle. But for this woman in Michigan, I actually told her the best thing she might do is partner with someone who's politically cleaner, so she could partner with a local gun shop. I suggested this, she didn't do it, but I suggested if you talk to a local gun shop and maybe go to some school fairs with the gun shop and give out gun locks or coupons for lock boxes. Gun shop makes money selling lock boxes. Have that as your partner. That's a strategy that's been used. It started in New Hampshire with the Gun Shop Project, where you partner with people that are on the other side of the political spectrum, so you don't get seen as a political intervention, but a medical one. That's all I can offer.
Thank you, Paul. Thanks so much for bringing so much energy to such an important topic.